In this video, I want to talk about the concentration of urine. That is, how your kidneys make concentrated urine. This is one of the very important functions of the kidneys. If you recall from our discussion of the physiology of the kidneys, water is excreted into the capsular space through glomerular filtration, but subsequently almost all of that water is reabsorbed back into the body. If the kidneys weren't able to reabsorb the majority of this water, we would have to be basically constantly drinking water. We need far more water than we do, and we would probably still be at great risk of dehydration. The ability of your kidneys to concentrate urine depends on a couple of different things. The first thing it depends on is the medullary osmotic gradient. This is a difference in solute concentration through the medulla of the kidneys, so that it's more dilute close to the cortex, but the solute concentration gets very, very high in the interstitial fluid of the medulla at the deeper levels. And this osmotic gradient is set up through countercurrent mechanisms of the loop of Henle, the countercurrent multiplier. It's also maintained by the Vasa Recta. The Vasa Recta has a role in making sure that osmotic gradient remains undisturbed. The second factor that the concentration of urine depends on is antidiuretic hormone, ADH. Antidiuretic hormone places aquaporins in the cells of your collecting ducts. It increases the expression of these water channels. And then the osmotic gradient in the medulla pulls water out of the protourine through these aquaporins. When I refer to the countercurrent mechanisms of the loop of Henle and the Vasa Recta, I'm just referring to the fact that you have the same fluid flowing in one direction, and in close proximity, that fluid takes a pin-like turn and flows back up in the opposite direction. So you have fluid flowing in one direction right next to the same fluid subsequently flowing in the opposite direction. Now, it's the flow of filtrate through the hairpin turn in the loop of Henle, this is called the countercurrent multiplier, that sets up the osmotic gradient in the medulla of the kidney, so that there is a high solute concentration deep in the medulla, and a lower solute concentration up near the cortex. The flow of blood through the Vasa Recta also involves countercurrent mechanisms, because the Vasa Recta flows very linearly, and blood makes hairpin turn through the Vasa Recta. That's called the countercurrent exchanger. Sometimes you'll see that term. And that countercurrent exchanger helps maintain that medullary osmotic gradient. I want to remind you that the juxtamedullary nephrons of the kidney are particularly important for the production of concentrated urine. They have very long loops of Henle that reach deeply into the medulla. So these guys are the primary countercurrent multipliers of the kidneys. This diagram over here shows you the relationship between the osmolarity of the filtrate and that of the interstitial fluid around the loop of Henle. So filtrate comes in the proximal convoluted tubule, flows down the descending limb, and back up the ascending limb. As that filtrate flows down the descending limb, it gets more and more concentrated, and then as it flows back up the ascending limb, it becomes less concentrated again. So now when this filtrate empties into the collecting duct and comes through the collecting duct, it's got a very dilute concentration. It has an osmolarity of about 100 milliosmoles. An osmol is a measurement of total solute concentration. So 1 mole of solutes in 1 liter of water equals 1 osmol. This countercurrent multiplier is helped out by a few different characteristics of the loop of Henle. First off, the portions of the loop of Henle in the descending limb that are permeable to water, but basically impermeable to solutes. So water can leave from the descending limb, but in the ascending limb, the loop of Henle is permeable to solutes, but impermeable to water. Okay, so solutes, largely sodium chloride, leaves the filtrate in the ascending limb, and water leaves the filtrate in the descending limb. I also want to point out that there is a equilibrium between the concentration of the filtrate and the osmolality of the interstitial fluid. So as the filtrate gets more and more concentrated as it moves down the loop of Henle, the interstitial fluid becomes more concentrated as well. So now let's talk about how the filtrate gets more concentrated. It all starts over here in the ascending limb with active transport of sodium chloride. Okay, so sodium chloride is actively pumped out of the ascending limb into paratubular fluid. So we're not relying on diffusion, we're not relying on osmosis, we're not relying on anything other than ATP to force sodium chloride out of the ascending limb. And that's where the countercurrent multiplier gets started. Well, at least that's how I like to look at it. When you have this sodium chloride being pumped out of the ascending limb, that increases the solute concentration of the paratubular fluid, right? So you have solutes being pumped out into the interstitial fluid. That's what I mean by paratubular fluid. It's the interstitial fluid around the tubules, or in this case around the loop of Henle. Now, since the descending limb is permeable to water, and it's right next to the ascending limb, water gets drawn out of the descending limb through osmosis. Okay, water can't come out of this part because this part of the loop of Henle is impermeable to water. So water is drawn out of the descending limb. As this water is drawn out of the descending limb, the filtrate gets more and more concentrated because it's losing water, right? So by the time it gets down here to the bottom, to the hairpin turn of the loop of Henle, it's highly concentrated. And because this urine is highly concentrated, or this filtrate is highly concentrated, you get more sodium chloride being transported out. There's more sodium chloride to be transported out into the paratubular fluid. Okay? So you have water being drawn out along here, sodium chloride being pumped out here, and that sets up this gradient in the medulla, where it's high solute concentration deep in the inner medulla. But the filtrate coming out of the ascending limb of the loop of Henle is very dilute, about 100 milliosmoles, so we need to reclaim that water. Before we get to reclaiming water from the filtrate, I want to talk briefly about the Vasa Recta first. The Vasa Recta also involves a countercurrent flow, only in this case we're talking about blood, not filtrate. Blood flowing through the Vasa Recta takes a hairpin turn. It moves down from the efferent arteriole coming from the glomerulus, moves down deep into the medulla, and then takes a hairpin turn, coming back up before leaving the nephron. The main key thing that I want you to get about the function of the Vasa Recta is this part over here, that the Vasa Recta allows for returning those water and solutes, the water and solutes that have been dumped into the paratubular fluid. The Vasa Recta is able to pick those up without disturbing that steep osmotic gradient in the kidney medulla. So you can keep your concentration gradient, your osmotic gradient, but not be constantly accumulating water and salt in the medulla. Now, the Vasa Recta doesn't have the differences in permeability that the loop of Henle does. Both the descending region of the Vasa Recta and the ascending region of the Vasa Recta are permeable to sodium chloride and water. But in the descending region, sodium chloride absorption dominates. So you get a lot of sodium chloride being reabsorbed as blood moves down through the Vasa Recta. So it gets pretty concentrated, the blood gets pretty concentrated at the bottom of the Vasa Recta, in equilibrium with the osmolality of the interstitial fluid in the medulla. As that blood turns and passes back up, water absorption dominates. Now you have water getting picked back up, rediluting that blood. And the main reasons why you don't disrupt that osmotic gradient are just because some of the solutes that are absorbed in the descending region don't leave in the ascending portion, and some of the water that's absorbed in the ascending region, more water is absorbed in the ascending region than you have leaving in the descending portion. So basically, you get the difference, you get the extra solutes and extra water carried back out, returned to the circulation. If the Vasa Recta just went straight through in continuous fashion without that hairpin turn, all of the salt in this inner medulla would leave in the blood. It would diffuse into the Vasa Recta and be carried away. And you'd get complete disruption of the medullary gradient. But because the Vasa Recta turns and flows in the opposite direction in basically the same space, in very close proximity, conditions are reversed, and you get to maintain that gradient. Okay, so you've got this osmotic gradient, and you're maintaining this osmotic gradient through the hairpin turn of the Vasa Recta. Now, how do you get the water back? How do you reclaim the water? Remember, your filtrate is very dilute coming out of the loop of Henle, so you still need to pick that water back up. This is where antidiuretic hormone comes in. In the absence of antidiuretic hormone, you basically produce a very large volume of dilute urine. Okay, so you get that low osmolarity filtrate passing through the distal convoluted tubule into the collecting duct and coming out your urethra. And you have this large volume of dilute urine because the filtrate is getting diluted, and the collecting ducts, in the absence of antidiuretic hormone, the collecting ducts are impermeable to water. Water can't leave the collecting duct. Now, when ADH is present, when antidiuretic hormone is present, you get the placement of aquaporin water channels in the principal cells of the collecting duct, and also some in the distal convoluted tubule. So you get aquaporins placed in. Now, the collecting duct is permeable to water. Much more permeable to water. And now, because you have this high concentration gradient, that's what's represented here, high osmosis gradient, osmotic gradient, this high concentration of solutes. Once these aquaporins are in the collecting duct, water is going to be sucked back out of urine. So you get to produce a small volume of much more concentrated urine. There is reabsorption of water that happens in the proximal convoluted tubule that does not depend on ADH. That's called constitutive water reabsorption. The reabsorption that's dependent on ADH is called facultative water reabsorption. That just means it's variable depending on hormonal expression. I do want to make the point that it's not like it's not like an on or off switch for ADH hormone. It's not like you either have no antidiuretic hormone or you have super concentrated blood and you need to turn antidiuretic hormone on. Antidiuretic hormone is actually released continuously, unless the only time when antidiuretic hormone turns off is if you have massive quantities of water intake in a short period of time and your blood solute concentration drops. So unless your blood becomes very, very dilute and you need to offload that excess water, then antidiuretic hormone can get turned off. So under normal conditions, ADH is continuously released at a constant level. However, when you need more antidiuretic hormone, you get an increased quantity of release. And this happens if your blood becomes too concentrated. So that's an indicator of dehydration. It indicates that you don't have enough water in your blood. So you need to hold on to more water. You need to retain more water from the kidneys. This also happens with a drop in blood volume or blood pressure. And then antidiuretic hormone is released in greater quantities. You get to hold on to more water, try to bring that blood volume back up and maintain blood pressure. Antidiuretic hormone is also called vasopressin. You may sometimes see vasopressin used more when you're talking about pharmacological administration of antidiuretic hormone. But it is a hormone normally produced by your body, produced by the hypothalamus, stored and released from the posterior pituitary. And if you think back to the endocrine system, remember we mentioned diabetes insipidus is the disorder that you develop if you have a lack of antidiuretic hormone. Now, since we're talking about urine concentration in this video, we might as well talk briefly about certain ways in which you can decrease your urine concentration and increase basically the amount of water that's expelled. A diuretic is any substance that increases urine output, and they may be prescribed to patients that have edema or patients that have high blood pressure in order to lower the blood volume, lower blood pressure down, and release some of that strain on the heart. There can be osmotic diuretics. Osmotic diuretics are basically substances that can't be reabsorbed, so they stay in the filtrate, and because they're solutes in the filtrate, they hold water in the filtrate. Mannitol and glycerol are a couple of examples of this. There are also diuretics that inhibit sodium reabsorption. So by inhibiting sodium reabsorption, they leave sodium in the filtrate. Water stays in the filtrate with that sodium. This is why caffeine is a diuretic, and there are a lot of pharmacological diuretics that act like this as well. You may have heard of one, Lasix, that's very commonly prescribed for hypertension. Alcohol is also a diuretic, but alcohol acts in kind of a unique way. Alcohol actually inhibits the function of antidiuretic hormone. So if you are out on the town, you have a couple too many beers, it's not just the fluid intake that makes you have to urinate, it's actually the alcohol inhibiting ADH. Okay, so after studying this video, you should be able to discuss how the kidneys generate concentrated urine, including, what two factors are required, talk about how that medullary osmotic gradient is set up, and talk about how antidiuretic hormone affects urine concentration. You should also be able to talk a bit about diuretics, what sorts of substances can act as diuretics and why.